completely superfluous. Complication of ICD, I don't have to tell you how many complications we observed, especially taking into account that you will implant ICD in a young patient, age 20 or 25 or 30. We should theoretically die at age 85. This patient, any patient who will receive an ICD for idiopathic VF or Bugada will have 60 years of implant and of course of complication, extraction, infection, dislodgement, psychological disorder, because nobody even told this patient that maybe there is another solution. Maybe you have quinidine. Maybe you have test quinidine with EP study, as somebody from Israel pretend that it may be the solution. Now, the big problem with ICD in IVF are the pediatric group, because the high incidence of ICD-related complication, and it is very important to try to avoid ICD until the child grows sufficiently. And this is important in this kind of patient to give quinidine if possible. And also the elderly group, because it's very rare to have the first IVF after age 70 years. And also because the arrhythmic risk recurrent decreases with age. So nobody addresses the question, what should be the age limit at which ICD will not be replaced? Don't you think that this may result in some medical legal problem if we say to your patient, who is now age 75, that, okay, he did his first IVF when he was 30 years, but now he's 75, maybe you're not obliged to replace it, especially that he get a lot of complication. Of course, the patient will agree, but if, for example, he died of any other reason, okay, non-arrhythmic reason, after 6 months, what will happen? I'm sure that his son will say, oh, he was so fine. My father was so fine with this ICD, but some doctor didn't want to replace it, okay? And I think the switch will only a matter of time. Now, as I told you, I think EP-guided therapy with quinidine is a fantastic option, but we need some requirements. We need that the VF will be inducible at baseline EPS. We need that the patient will accept, will even prefer antiarrhythmic medication over ICD. We need that the medication will be tolerated. We need also that the patient will show an excellent drug compliance. We need that the patient will have a good psychological profile, not to stop medication after 6 months. And also we need to check that EPS will show after 5-10 years that the ventricular fibrillation of drug is not inducible more. Now, for that have been used what I call an aggressive protocol of programmed ventricular stimulation. This protocol is usually the standard one, okay, that you are all using. But if this protocol is negative, what I'm doing is to repeat it using stimulus current of 5 diastolic threshold, but always less than 3 milliampere. I do not limit coupling interval. It's very important for this patient to give extra stimulus coupling interval as short as possible. And also very important, if you want to induce VF in this patient, to repeat extra stimulation at the shortest coupling interval associated with ventricular capture, and I usually do it 10 times for double extra stimulation and 5 times for triple extra stimulation. Of course, for the RVA, for RVOT at the cycle length 600. So I only prolong by no more than 10 minutes the protocol, but I increase dramatically my chance to have a positive inducible electrophysiologic study. When I reported my results on IVF, and some patient got it, was in 1999, I can tell you that the follow-up, I had inducible VF in 80% of this patient, and the patient using quinidine was no longer inducible in 96%, almost 100% of patients. I'm also using high doses. I'm not using 1 milligram because I think it's very important if you decide not to implant an ICD to have a patient non-inducible with quinidine. So I'm sure that with a patient with 100 milligrams of quinidine, of course, will be inducible. So the dose are not the same. The dose we stops, we prevent an arrhythmia clinically, and the dose we prevent the induction of an arrhythmia is completely different. And also very important, I talk to you about that, to repeat, to test the reproducibility of electrophysiologic efficacy of quinidine. I will show you a fantastic case. In 97, 57-year woman who had a lot of syncopal episodes which were related to non-sustained and even sustained polymorphic VT with sharp coupling interval, normal heart. I did baseline electrophysiologic study. I was able to induce sustained polymorphic VT-VF with 3 extra stimuli from the apex, and I gave during the same session IV procainamide and was enabled to induce sustained polymorphic VT. This is an excellent sign. When you use low dose of procainamide, 500 milligrams is a very low dose, and we are enabled to induce VF, this will be a good indication that you will be very effective also with quinidine. And exactly what happened after giving quinidine orally. You see that I am enabled with using even 4 extra stimulation, not 2, not 3, not 5, 4, what you want. Impossible to induce, to reproduce the induction of VF with quinidine. But about 10 years later, quinidine was not available in our country, so I have to take the Sereco from Sanofi, from France. So I repeated the study using the new salt of quinidine, which is an hydrochloride salt instead of a bisulfate, what I was using previously. And you see again, using the apex repetition, what you want, impossible to induce nothing more than a single VPB. The patient died of unrelated cardiac origin about 28 years later, about last year. Now, what is my experience with quinidine? 40-year experience. Drug discontinuation, about 30%. Never QT prolongation requiring drug discontinuation, never. When you have a normal ECG, no familial history of long QT syndrome, the probability your patient will develop long QT problem associating with anosade de pointe and VF is 0. The side effects are transient, always resolving after drug discontinuation, and no long-term sequelae. Limitation of quinidine therapy, of course, are the drug-related side effects. The late drug intolerance with refusal for getting ICD, this is a problem. A patient told you that, okay, he's agreed to take medication. After 2 years, he stopped medication. He doesn't want ICD, and you cannot, it's difficult to convince now he doesn't want ICD. But if I had implanted ICD before, of course, it would be much more better. But now I have a problem with a patient who doesn't want ICD. It may be in danger. And also another limitation is the late poor patient compliance. A patient took medication 5 years. He said, I'm okay with medication now. I want to try to stop. This is a big problem. I have to recognize this is a big problem. This is a rare problem because I'm selecting the patient. The psychological profile here is very, very, very important. Now, thank you, Sami Viskin, for telling us that coronavirus has been all in red, but also in red are the, no, I'm joking here. In red are all the countries in which quinidine is not available. So this is another big problem. Now, blind quinidine therapy, I show you the case from Oslo. This is a possibility. I think a doctor today should tell his patient there is a case in the literature in Oslo described, published, and okay, that there is a possibility. I will give you quinidine, 2 tablets. You may die at age 90 from something else than recurrent idiopathic ventricular. I think we should be honest and we should tell that to our patient. And Dr. Basil Rudetsky, who died only a few months ago, wrote in Chest in a paper entitled Quinidine as an Antiarrhythmic. He wrote, "Be not the first on whom the new are tried, but not the last to lay the old aside." Now, management of idiopathic ventricular fibrillation also include catheter ablation, and this is mainly due to the pioneer work of the genius. I call him the genius, Dr. Michel Issaguet from Bordeaux, my good friend. And this is based mainly on the important role of the Purkinje system as the predominant source of triggers for the initiation of idiopathic ventricular fibrillation. And now everybody knows who is working in this field that there are three zones of predilection of triggers of VPC. The first is on the right ventricular Purkinje, you see here, right ventricular Purkinje. The second is the left ventricular Purkinje. It may be the, let us see, the left posterior fascicle or the left anterior fascicle. Okay, excuse me, left anterior fascicle. Both are here, are located here. Also, the F is the papillary muscle, also may be involved. Myocardium, much more rare, and of course, the RVOT and the LVOT. But I would say that 70% of the cases came from the Purkinje system on the right apical side and the left side of left posterior fascicle of left anterior fascicle. This is very important. I will show some case. And this is the demonstrative curious morphology of this VPC for the RVOT. This is well known for the RV Purkinje. And for the LV Purkinje, you see you have a lot of VPBs with the right branch block pattern with various axes. You have here the Belhassen curious morphology. Okay, it's okay to give Belhassen, RBBB, left anterior, it's okay. I do agree with this classification, but you also have the RBBB right axis and many intermediate morphology between both. Now, Michel Issaguet reported on the very nice Purkinje electrogram recorded here in a patient, and here in the left ventricular Purkinje. Look to that and look to this one. Thank you, Michel Issaguet. Now, I would like to conclude. I know you have additional time, maybe, because I have here a case, a fantastic case, because it has been done, one in February and the other one a few days ago. And this case has been performed in Hadassah when I'm working, but I was at home when it was done. This is terrible for me, terrible. So I didn't attend the case. The first ablation was done by Dr. Bitton and Dr. Elizzo in February of this year, 2 months ago. And the second case was made by Professor David Loyer and also Dr. Bitton a few days ago. Now, we are dealing with a young 14-year-old boy without any familial history and apparently no obvious channelopathy. This patient at age 6 years old underwent ASD surgery, and he developed later some kind of bradytachycardia and tachycardia with a lot of episodes of atrial fibrillation. CRTD was implanted after he already had also a ventricular arrhythmia. So this is a guy who had CRTD. He had apparently normal RV and apparently normal LV, and a lot of episodes, short, longer episodes, many shocks of VTVF. Most of VT are polymorphic, and these VF are refractory to high dose of quinidine. I'm very surprised, but I also seen a Brugada patient, a young patient who was refractory to quinidine and in whom have been obliged to make epicardial ablation. But this patient also, maybe the age plays a big factor also in quinidine inefficacy. So he received a lot of medication, all is ineffective. He was even placed in high priority in the list for heart transplant. So this guy should have undergone heart transplant 3 months ago. But he was referred to Dr. David Luria from ablation, maybe ablation. And in February, you see that this patient had this biventricular pacing and a lot of monomorphic here, looks monomorphic ventricular tachycardia, triggered by this kind of VPC. This kind of VPC has a right branch block pattern and apparently a right axis deviation. Now, the patient arrives in the hospital and almost no sustained or even short-lasting polymorphicity, only a few VPBs which apparently were clinical. What did at the same time, it was during the night, Dr. Bitton and Dr. Elitsuo, they tried to make pace mapping of these VPBs, and they obtained a good pace mapping, a fantastic pacemaking, I think 89% correlation with the spontaneous VPBs at an area that they think is the anterior lateral, not far from the left anterior fascicle. And interestingly, during the ablation pulse, they obtained some ventricular activity. The ventricular activity obtained during the pulse was almost identical to the spontaneous recorded VPCs. So I think they did a fantastic job, and really all the episodes disappeared. We are happy that 2 months, 3 months, the patient had no other episode. But what happened after 2 months? Again, ICD, storms, but of course, ventricular fibrillation. But if you look very, very closely now, you see something that I think fantastic. You have a Holter monitoring of 12 lead. This 12 lead shows that you have pacing here, pacing here. I think this complex here is a spontaneous complex of aberration beat, because you have sometimes rapid atrial fibrillation. This may be also a fusion beat. Personally, I think this is an aberrant beat, because here I think is the initiation of a ventricular fibrillation here with a complex which has a very short coupling interval, but has a right bundle branch block pattern. You see the RSR prime here in V1, but here you have a left axis. And presently, in 2 months ago, we had the right axis. So we are dealing with some different focus. And now Dr. David Luria takes the patient as an emergency case also, and also find and ablate several areas in the areas of the left posterior fascicle. After he recorded some fascicle here at the very close to the left posterior fascicle, which was preceded by 24 milliseconds, the onset of the Cure's complex of the first initiating beat of the ventricular fibrillation. I'm personally surprised, I told it yesterday when the case was presented, that the coupling interval here was long. Personally, I believe there is something else in other location which is blocked. It means we are not here at the best location of the initiation. Maybe we have something here with a percutaneous potential which is blocked, but in another area. I don't know. So, of course, I didn't tell you this, the end. The patient had abolition of his ventricular fibrillation, has been doing very well, and have been released with his short ED and no arrhythmia. As really congratulations to all the staff of Hadassah. Now, I think I will stop here and maybe we can discuss. If you want me to show you a fantastic case of a woman who had Brugada syndrome and diagnosed as idiopathic ventricular fibrillation and was inducible with one single ventricular extrasystole, I will do it. It was in 87, no, excuse me, yes, 85. But first of all, maybe you have some important question, and I'm ready for the question.
Thank you, Professor Belhassen. There are a couple questions that have come through. You said you were going to, go against the grain and guidelines, and we got a sense of that with your thoughts on ICD. There was a question about your thoughts on subcutaneous ICD versus transvenous ICD. Do you have any thoughts on that?
I think in Hadassah and also in Nihilo, where I was working, we don't have a lot of experience with subcutaneous. I don't know. I cannot comment on something really. I have no personal experience. I saw in the literature that maybe some problems with, I cannot connect. I prefer not to comment the field with, I'm not, fluent with it. So,
and if you give an ICD, you routinely give quinidine?
What does it mean?
If a patient receives an ICD, is your antiarrhythmic drug of choice for a patient with the ICD to get quinidine?
Okay, I think it's a good question. I think if a patient, we have two kinds of patients, which is the same with Brugada and with idiopathic VF. If a patient has arrhythmic storms, now I'm trying to be a US doctor here, okay? I'm a US doctor, of course I will implant an ICD and so on. Okay, so if a patient has a rhythmic storm of idiopathic ventricular fibrillation or Brugada, and of course we implant an ICD, I will absolutely give additionally quinidine, absolutely. If not, I have to explain to the patient that he may have arrhythmic storms. So if you want to be dangerous with arrhythmic storms, this is his problem. But I think it's important the patient will be discharged on quinidine. Sometimes small dose. I'm not talking here of giving 1,500 milligrams. It has an ICD. So I think sometimes 1 tablet to 2 tablets a day of quinidine, which are perfectly tolerated, will be effective. Now, if a patient has an ICD implanted, but only a single episode of ventricular fibrillation, of course, I will not give quinidine. Of course, quinidine is reserved only for those patients who will accept not to get an ICD and will be agree to make EP studies and so on, as I talked, the EP guide therapy with quinidine. Okay, only this kind of patient will receive quinidine at usually much more larger dose than 100 or 300 milligrams. Yes.
And then the other drugs that you use in those countries where you can't use.
Okay, this is important. In countries where quinidine is not available, I'm not sure that disopyramide is available. Okay, I think disopyramide should not be available. So I think there is a problem. The problem is if the patient receives quinidine, he is very happy with quinidine, but he develops side effects due to quinidine. But he doesn't want an ICD. What to do? Very simple. I think we can try the second class 1A agent that can be tried here is disopyramide. Disopyramide, unfortunately, I have experience only in 3 patients. It works exactly as quinidine works. Exactly as quinidine works. The only problem is in male patient prostatic problems, urinary problem, but no problem usually are observing in females. So I think should be an excellent medication. Now, I will not give this disopyramide without doing repeat EPS. Okay, so I will do EP guide therapy with disopyramide. Of course, I will never give a medication without ICD if I'm not sure that the medication will not be effective in the cardiac lab in preventing ventricular fibrillation. I saw now another question. Is he sending genetic testing on any of these patients? First of all, I want to tell you the truth. We have been exposed to genetic testing only during the last year. So I will see my 90% of my patients in Ichilov has no genetic testing. According to genetic testing, I think there is a very nice paper, I think it came from Canadian. And in Canada, they discovered, I don't think Canada, or think maybe from Holland, excuse me, I think from Holland, in which they showed that a small proportion of patients in whom a diagnosis of ventricular fibrillation was done, IVF was done, were in fact genetic disorders and so on. So I personally completely agree. Today, genetic testing should be a part of that. It's not a matter. I think you have excellent genetics testing with $300 or $400 or $500. I think it's nothing today. So it's not a problem. I strongly in favor of doing genetics testing to any patient who had ventricular fibrillation and apparently normal heart. Now, other questions?
Yeah, there were a couple on whether you're doing serial EP testing at various doses of quinidine.
Fantastic question. Because my experience on the field, for example, when I was using bisulfate quinidine, I know that when I tested first 1,000 quinidine, I was a little bit disappointed. And I have to move to 1,500. So what I was used to do is first to try the maximal, not maximal, the tolerated dose of quinidine the patient may suffer, okay? And usually with 1,500, which was fine, and I'm doing the study. Now, in some patients who develop some inconvenience with drug, of course, I will propose them to repeat the study using 1,000 milligram, and I found this 1,000 milligram was effective, okay? But usually I prefer to start with a maximal tolerated dose and decrease it and not to do the inverse, because this, if a low dose is negative, it's not effective, I have to repeat the study. It's a problem. I prefer to make only one drug study and not 2.